it. So life is beautiful, and nowadays, if you will think of all these UGC curriculum and everything is undergoing a lot of changes. So in recent years, what I have found, it is more and more becoming flexible. It is quite flexible about doing PGs and flexible about even interdisciplinary courses. So we must take benefit of all these things. So whatever these things are going on, you should actively participate in discussions. Medical is yet to be included. Engineering is going really haywire, and they can do their post graduation in any subject, whichever stream they are from. So likewise, if it has been possible about the medical education, so that will be great. But for that, we have to be proactive. We have to do these things. Change, if at all you want to bring, so you will have to start it from yourself. So change is imminent. Everything is going to change over the period. AI is coming in big way. So what exactly AI? AI is doing whatever the possibilities depending on black and white picture. What we are talking about is the same thing what AI will be doing. Although without insight, it will be quite difficult to. So regarding the insane AI and sane we, I think we will be having upper end in the future. Whatever things are, if you are increasing your skill, you are learning new things, these are always welcome and really great. I will be always there to help you. Sir, should we start or should wait for
I think we should start.
this? Almost 11 participants are there. So the first one, I have labeled it as a spotters. Spotters are the things, means spotters are nothing but X-rays. Just go through these X-rays. Can you see this one? Which X-ray? Which part of the body?
Chest
The
X.
Radiograph chest
chest
PF.
X.
And if you will apply A, B, C, D, E, F here, what you will find, A is for airway. What had happened to the airway?
Trachea shifted to left, sir.
Yes, very good. So trachea is shifted to the left. So whenever there is a shift of trachea, it is either due to pull or push. So push will be if there is large pleural effusion and it is pushing trachea to the opposite side. Sometimes there can be a picture like this. What you can see here is the almost homogeneous opacification of left lung parenchyma. Okay, so left hemithorax is having complete opacification.
Tracheal winding, sir. Bifurcation.
Uh, okay, tracheal widening is not that much. Usually, this trachea is overlapped by fractures. And
So
because of
lung
the,
fibrosis could be possible.
yes, lung collapse is there. So on left side, lung collapse is there. That's why compensatory hyperinflation of the right lung parenchyma, what one can see here. And this is a retrocardiac, although heart has also shifted to the left. So it is not only trachea, there is a shift of mediastinum and heart to the left, with that opacification of the left hemithorax, which is due to a complete collapse of left lung. Why there is a collapse? One has to look carefully at the airway. So I'm looking at the airway, I can see right bronchus, intermediate bronchus, upper lobe, then we are having lower lobe bronchus. So one can follow airway very well on right side, but on left side, when I'm trying to follow it, I can see trachea, this one is carina. This means the left main bronchus. There is a complete cutoff at this level. See here, where I am pointing is the complete cutoff of the left mainstem bronchus. That's why there is a collapse of left lung parenchyma. This is called bronchus cutoff sign. So whenever bronchus cutoff sign is there, it is usually due to the malignancy. Malignancy, that is a bronchogenic carcinoma involving left mainstem bronchus, and there is a complete collapse of left lung and such type of picture. Heart is actually overshadowed by this collapsed lung parenchyma. So silhouette sign, silhouette of the cardia cannot be made out. Even the diaphragm, we cannot see a silhouette of the diaphragm. So there is almost a homogeneous radiopacification of the left hemithorax with obliterating the cardiac as well as diaphragmatic silhouette. Shift of trachea, that is a volume loss, what we call it. So shift of trachea, heart and mediastinum to the left. And with bronchus cutoff sign, it is most likely a left hilar malignancy or the central malignancy. So whenever mass is towards the center, it is a squamous cell carcinoma, and adenocarcinomas are seen in the periphery. So this one is left lung atelectasis or complete collapse of left lung. Again, another chest X-ray. This we have already discussed. What are the structures I have pointed here? Yes, anyone?
The pointer right side, there is a
red hilar lymph nodes.
Hilar lymph node.
Basically, the structure what I am pointing is the hilum. Okay, so this one is the right hilum and this one is the left hilum. So which hilum is at higher level, right or left?
Right one.
No, in this case it is right, but usually it is
Left,
a left. Yes, left hilum is at higher level as compared to the right, because if you look at the left bronchus and left pulmonary artery, actually left pulmonary artery, it arches over the left mainstem bronchus. So you will see left mainstem bronchus is there and pulmonary artery is going like this. So that much distance of pulmonary artery is added, and that's why left hilum is at higher level as compared to the right hilum. And that too, if approximately you want to remember it, we will talk in terms of intercostal spaces. So one intercostal space above as compared to the right hilum. So left hilum will be at higher level. At the same time, if you will find diaphragm, so left diaphragm is at lower level. Okay, so these are the basics. So right hilum is shifted upwards. As we had seen, trachea was shifted to the left. Here, right hilum is shifted upwards with, there is a collapse of right upper lobe. In such cases, yes, whenever one can see minor fissure pulled like this, you can comment directly like this is a right upper lobe collapse. So you'll remember it. So never forget to look for the position of hila. Can you see anything else in this particular radiograph? Anybody? We can move forward, no problem. There is another small patch of consolidation is here. That's all, okay. So we will move to the next one. This one is the right upper lobe collapse or atelectasis. Again, you can see same thing, but now see volume loss is not that much. And one can see air bronchogram within. Can you see air bronchogram? Air bronchogram means air is there in the bronchi. So all these tertiary and secondary bronchi, they are filled with air. And as one can see, the consolidation or the opacified lung parenchyma or the alveolar opacity, as one can see here, with air bronchogram within is pointing towards a consolidation. So if you will look at the collapse air bronchogram is not there because air is not entering inside the lung parenchyma. There can be two reasons for the collapse. There is something called active collapse and something called passive collapse. Whenever active collapse is because of some sort of push and pull phenomenon, what we had discussed before, passive collapse is whenever the bronchus is obliterated and there is a absorption of the whatever air was there in alveoli, so that will lead to the passive collapse. So passive collapse reason is obstruction to the bronchus. Active collapse, something is pushing from the outside. So this one is consolidation. So I think you will be able to differentiate between collapse and consolidation. Sometimes it may be difficult to differentiate in between. So you can use a combined term like collapse, consolidation. So this one is a consolidation of right upper lobe. Now anyone who can see any findings, you just start describing. Yes, Sanket. We had seen this radiograph. We are just repeating these radiographs again and again. What are these densities? Which density this one is? Whether it is a calcium.
Metallic density, that is post CABG, I think.
Surgery is done.
And there is cardiomegaly, I think.
Sternal sutures are there, okay?
Yes,
Cardiomegaly plus minus. Actually, I haven't included that much part. Can you see this thing? What it can be?
yes, there is obliteration of the
So post cardiac
CP angle.
so bilateral angles are obliterated, means bilateral effusion is there.
Yes.
That's the incidental finding of this thing, which is a azygous fissure. Azygous fissure is the accessory fissure. Azygous when it drains into the There is a azygous and hemiazygous system, a parallel system to the systemic venous drainage. So this azygous venous system, it drains into the superior vena cava.
Superior vena.
So the
Aunt
head,
mini, aunt, no, something is aunt mini is called something.
uh,
Azygous fissure, sir.
azygous fissure. Azygous fissure, actually, I don't know any other name is there or not. But the whatever the part of the lung which is medial to it, and if it gets entrapped, this one is called azygous lobe. So azygous lobe and azygous fissure. So there can be a pure consolidation of azygous lobe. Although this is not that common, but if at all you are looking at it, these are not fibrous band, as hyla are at normal level. As one can see, left hilum is certainly at the above level, a higher level as compared to the right. So we'll move to next radiograph. Yes, sometimes you may come across such type of radiographs, but diagnoses are really important in these radiographs. Patient may come with history of breathlessness. So patient is coming with breathlessness, so we should be very cautious about.
Is this COPD?
COPD,
No, it is not COPD.
emphysema,
No, it is not emphysema. Whenever we are looking at a bronchoscolar marking, so look for the bronchoscolar marking. They are quite good and they are reaching up to the lateral 2/3. So vascular marking basically, they are reaching up to the lateral 2/3, more than half. So emphysema or the COPD will have a less than half of the lung parenchyma with very much decrease basically vascular markings, and there will be prominence. So
Pneumothorax, it's good.
yes, very good. Pneumothorax is there. So this one is the diaphragm will be also flattened in COPDs. Heart will be somewhat will take a tubular cyst. This one is the pneumothorax. If you look carefully, you can see this one is the collapsed lung parenchyma. What is seen in this intercostal space? So second intercostal space, you can see collapsed lungs. So the spontaneous pneumothorax is not that uncommon, although spontaneous pneumothorax is frequently seen in COPD patients. So you may come across a patients with emphysematous bulla and one of the bulla had ruptured and such type of, so there can be overlap in between these pictures. So be cautious about looking for the collapsed lung margin or such type of alveolar margin or visceral pleural lining. If at all you can see, this is very much pointing towards the small pneumothorax. Small pneumothorax you may miss, but they are not life-threatening. So it's the small pneumothorax, but whenever it is associated with the shift of the mediastinum, then one should be very careful about. So this one is a tension pneumothorax and never to miss that diagnosis. So we are moving to the next. Can you see something here? Or just very difficult thing?
CCF,
CCF,
This is not miliary tuberculosis.
congestive
Like-
cardiac failure changes.
CCF,
CCF is the diagnosis. However, we are not directly jumping to the diagnosis. See here, this one is cardiomegaly. Cardiomegaly is certainly there. See the cardiac diameter and see your transthoracic diameter. So cardiac diameter is almost 60 to 80% of the transthoracic diameter. So cardiomegaly is there. With the cardiomegaly, bilateral hilar prominence. Bilateral hilar prominence and descending pulmonary artery is dilated. See here, it is more than 2 centimeters. So more than 1.5 centimeter in male and more than 1.2 centimeter in female. Descending pulmonary artery, at least measured 1 centimeter from the hilum. So this one is a case of pulmonary edema. So diagnosis is correct and bilateral central distribution of the opacities. So these are all heterogeneous opacities which are seen centrally placed. So this one is the extensive case. Sometimes you may come across a pleural effusion as well. And Curly's B-line, what we had seen in few cases. So let's move to the next case. So this one is a pulmonary edema. So diagnosed very well, but you should be careful about the diagnosis. You can just start commenting about this patient. Almost a middle-aged female patient. She is to you. You can see something is placed here.
Sir,
What is
pacemaker.
very good. So there is a pacemaker. So pacemaker can be a single lead or dual lead pacemaker. There can be sometimes a 3 leads as well. There is something called defibrillator and something called pacemaker. So how to differentiate between defibrillator and pacemaker? So you can just look for these things. So sheath is there. So you can, this one is externally placed pacemaker or the defibrillator. That's all. Very good. And the placement of the lead, if single lead is there, it is usually in the right atrium. And if two leads are there, another lead will be in relation to the interventricular septum. So left ventricle. Now let's see any other findings other than pacemaker. Why there should be such type of defibrillator or the pacemaker placed in this particular patient? These are chest leads. Okay. What happened to heart?
Yeah.
What is wrong with heart?
Cardiomegaly.
Very good. So there is moderate cardiomegaly. What one can see here. See transthoracic diameter and look for the cardiac diameter. So there is a gross cardiomegaly or the moderate or massive cardiomegaly. And in this patient, why I am showing you this patient? To show you a similar spectrum. How early you can catch up the pulmonary edema. So what will be the earlier feature of the pulmonary edema will be some interstitial lines. We had discussed it previously.
Curly B lines we are
Curly
showing.
B lines. Can you see curly B lines? I will show it to
Yes.
you. So this picture actually is for to show you a curly B line. So see
And
here.
the right lower side.
These are all curly B lines. Curly B lines are parallel to the such type of parallel lines which are little bit separated from that of the parietal pleura as well. So such type of lines you will find in lower lobe region, peripherally or the lower zone, what we will call it in the chest PA. And such type of lines are there, not more than 2 centimeter in, lot more than 2 mm in thickness, and multiple lines as one can see here. So this one is the early pulmonary edema and curly B line. Can you see the magnified part better? All these are, all
Yes.
of them are curly B line. Sometimes these are non-branching lines. Okay, Curly's B lines are non-branching. Curly's A and C lines, now combinedly they are called C lines. So Curly's A and C lines are basically a venous and they are branching type and they are mostly directed towards the hilum or basically pulmonary veins. So little bit downward direction can be there. That's why I said mostly directed towards the hilum. So this one is pulmonary edema early picture. You had seen that extensive exuberant sort of picture, the radiograph before this. Now we will discuss something. Okay, so what you were saying about is this thing. Can you see anything here?
Pneumothorax is there, left side.
Yeah, center diaphragm.
Okay,
Left lung, mid lobe, middle lobe.
this colon. Okay,
COPD.
feel like okay. So look for these different changes. So at first make it a habit to look for these things. Okay.
Hilar region.
Yes, you are right. You are just moving on right direction. So
There
COPD.
is also consolidation in the middle lobe of right lung.
Okay, so some heterogeneous opacity is also there with some prominence of the right descending pulmonary artery. So there can be a core pulmonary part as well. So whatever you said, each and everything is seen in this particular picture. You can see flattening of diaphragm here. I'm just adding to your findings. This is a flattening of,
CP angle also, yes.
and if at all you are thinking it as a emphysema or thinking it as a pneumothorax, both can be correct. If there would have been, you can see a part of lung is collapsed, but this may be due to a large emphysematous bulla, or as one can see some bronchovascular or some vascular markings here, but vascular markings are certainly not reaching up to the periphery. So in emphysema patient, there may be a associated pneumothorax. So just these things goes hand in hand. But if there would have been a shift of mediastinum, we would have commented more about it, and it should be taken as a which pneumothorax? Tension pneumothorax.
Tension pneumonia.
We need to drain it. This is a patch of consolidation. Okay, so there can be a recurrent infection because of the hampered drainage and ciliary problems, and one can see such a emphysematous lung. So all of you are right, and carpulmonary is in this emphysematous COPD patient, you may come across normal size heart because tubular heart is there. Even a normal size heart, if at all there can be associated pulmonary edema, or there can be associated a cardiac failure as well. Cor pulmonary means secondary to the COPD, there can be a development of a cor pulmonary. Yes, anyone?
Left
Consolidation in
lung middle lobe,
left middle.
left middle lobe.
So what type of malignant masses will be central and what will be peripheral?
Squamous cells.
Very good, Rajesh. So squamous cell carcinoma, they are
Yeah.
central and peripheral
Central.
adenocarcinoma. And
Yeah.
we were also talking about bronchus cutoff sign. We had seen it in one of first case. That bronchus cutoff, you may come across such type of picture. But bronchogenic carcinoma can have a presentation like that of a consolidation or the round pneumonia. Whenever pneumonia is confined to like this and well defined, maybe round pneumonia, but that will disappear in the follow-up radiographs. So clinical findings are clinical, rather a clinical, whatever the complaints patient is telling us about, the clinical knowledge is always, a clinical profiling of the patient should always be done. See here. Another thing, you had seen this mass and you are looking at something here in the same region. Can you see it?
Yes, sir.
So
It's like a cavity.
yes,
Like,
these like cavity. So whenever thick walled cavity is there, so you must suspect a malignancy. What will happen? Squamous cell malignancies, they are necrotic. So this necrotic material may get drained through the bronchus. And what will remain there is such type of cavity. Even abscesses, they can have similar appearance, but they are usually thin walled. Then loculated pneumothorax can also have similar appearance, but thin, thick-walled irregular cavity is pointing towards the malignancy. And in this particular case, a squamous cell, this patient had a squamous cell carcinoma. So these are cavities with metastatic cavities of the squamous cell carcinoma. Another case, we are moving ahead with similar appearance.
Right-sided cavity lesion.
Okay, so you had seen this lesion first. So right side cavitary lesion, similar lesion. So highlighted cysts, abscesses, squamous carcinoma, many necrotizing sort of malignancies, they can drain into bronchus. And
Gas under diaphragm also in left side.
so this one is with horizontal level and with this distance, almost a centimeter size thickness here. This one is a gastric bubble. So gastric bubble just, this is a normal finding. So what one can see here also, it appears like that of in subdiaphragmatic region. So what you should remember, the posterior part of the lung, it goes much posteriorly behind the liver. Anterior diaphragm is at higher level, posteriorly it is at lower level. So such type of picture may be seen with posterior lung masses or the posterior lung cavity. So this one is actually in the posterior part of the right lower zone or lower part of the lung. Similar thing you can see here. Can you see here?
Sir, can it be a bronchiectasis, like changes in the
Bronchiectasis,
bronchioles? They are widened actually.
they will not reach up to such a large sizes. Incidentally, this patient had multiple such type of lesions. So multiple lesions,
is it consolidation, sir?
necrotizing type of pneumonia can have similar presentation and consolidation with nematocele. Nematoceles formations are quite common in children. So their cavitating necrotizing sort of consolidatory lesions can have such type of appearance. In this particular case, this patient had all these hydratids. They had a hydatid disease.
And bronchovascular markings are very prominent all through the chest.
Whenever infected, yeah, bronchoscopy marking are almost reaching up to the lateral two-thirds. So this is because of the congestion. So whenever congestion is there, bronchoscopy marking will reach up to the lateral third of the chest. So congestion is just pointing towards some sort of infectious process which is going on in this particular lung, and these patients turn out to be a lung abscesses. So patient is having multiple lung abscesses, and these are patches of consolidation as well. Okay, good. This one, we had already discussed about this case. Yes, anyone? Try to diagnose.
There is a air bubble below left diaphragm.
Okay, so you feel there is air below left diaphragm. This one is gastric or the fundic bubble. Okay, so gastric bubble is there, and this one is separate air. What is seen in the left? What about right? This
There is a
one,
flattening of diaphragm.
not flattening.
Or
Actually,
not flattening, but I mean, the
so
levels are more likely.
So this means the gas under almost both the diaphragm. So gas under diaphragm is there. However, some hostile folds can be seen in between. So whenever hostile folds are seen, these are more likely cases of
Yes, sir.
Chilaiditi syndrome. What we had discussed, the colon get entrapped between a diaphragm, the liver, and here colon is entrapped between the stomach and the diaphragm. So this is Chilaiditi syndrome. However, you cannot differentiate unless and until you are quite sure about whatever you are looking at. These are nothing but a hostile folds which are characteristic of the large bowel. So if characteristic of large bowel you can see, then only comment about the Chilaiditi syndrome. Otherwise, just go ahead with some gas under diaphragm is there. However, you don't feel this one is a free gas under diaphragm. So although this gas under diaphragm is there, this is not a free. This one is a Chilaiditi syndrome when colon is entrapped in between. We will also look for another case also we will look for. So see here, this is very simple case. Very simple case. This,
Right middle lung, there is some consolidation. Some patch is there.
very good. So there is
So
patch.
maybe a pneumonic patch or something,
Yes.
or
This,
some infection.
okay, so you feel this one is infection. Anything else? Start from the airway, A, B, C, D, E, any other finding? Right? Look in all corners of the area. If you can point out this thing, you will be knowing what exactly this consolidation is or what exactly this thing is.
Right upper lobe consolidations.
It's okay. We have already discussed about by talking about the chest radiograph, we talk in term of zones. So this one is a first rib, this one is the second rib. So inferior part of the first rib. So this one is the mid zone. So in mid zone, some consolidatory patch or heterogeneous pneumonitis sort or consolidatory patch is seen here. So heterogeneous alveolar air opacities or the heterogeneous radio opacities are seen in right mid zone. This is okay, but what these opacities can be, this can be simply a consolidation as we had discussed. But look at this thing.
Hello.
What is wrong here? Yes, Jerry.
Fracture is
So this was pointing to us what exactly this pathology can be. So sometimes you may come across such type of
fracture clavicle.
Clavicle fracture. Yeah.
fracture clavicle along with this thing. These contusions, you cannot differentiate contusions from that of consolidation. Okay. So don't worry, your diagnosis is correct, and this is more of this one is a lung contusion with left. This one is the fracture clavicle. This is pointing to us. Okay, so there is I have labeled it as a consolidation, but that consolidation can be a lung contusion, same thing. Now this one, I think everybody should be able to diagnose.
Pleural effusion, meniscus sign.
Left-sided pleural effusion.
Yes, so we are having left side moderate pleural effusion obliterating the cardiac as well as left diaphragmatic seal out. So we will move to the next radiograph. Yes, this one is little difficult to diagnose, but
Cannonball shadows are there.
very good. So there are multiple such type of rounded opacities which are seen in bilateral lung parenchyma. In a known case of a malignancy, all these are metastasis. So what metastasis can be seen here in the bilateral lung parenchyma? So cannonball metastasis can be there in germ cell tumor, can be there in even renal. So these are not so uncommon thing. Look at this particular radiograph. The appearance
Bag-like heart.
money bag like heart.
Money bag-like.
Money bag like heart is actually because of the pleural effusion. No, pleural pericardial effusion.
Pericardial.
So pericardial effusion. Here is the pericardial effusion and typical appearance of a heart.
Is it money bag or that water bottle?
Whatever you want to. All these
Pericardial.
all these labels are given. Leather bottle. Leather
Leather
bottle
bottle, yeah.
used for
As a pericardial.
yeah, you can use all those terms. Whatever typical structures they were coming across, they started labeling it as a science. And so leather bottle basically used for stomach because they used to carry water in that some आपण त्याला काय म्हणतात पखाल वगैरे काहीतरी ते राहायचं बनवायचे ना.
पखाल. हा.
मग इथे आपली ते आजीबाईंच्या चंची सारखे दिसते मला ही नेहमी.
Yes.
म्हटलं तर ओनली दोज मराठी पीपल दे विल ओनली रिमेंबर की व्हॉट एक्झॅक्टली दिस वन इज. सो
पिशवी.
येस सर.
पिशवी.
हा, पिशवी कोणती पण, आजीबाईची चंची म्हणा, पिशवी म्हणा, किंवा ही मनी बॅग. सो फ्रिक्वेंटली कॅरीड. Yes, that you can use. Another case with almost similar appearance. Age is a child. Okay,
Yes.
child. So we are looking at thymocardiac cell out. But how is the appearance? Sometimes there can be a cardiomegaly. This is difficult case. Okay, I do agree. This one is the thymus and thymocardiac cell out is mildly enlarged in size. Actually, I wanted you to comment about this thing. What is this structure known as?
Widening of cranial angle.
Yes, widening of cranial angle is there. So whenever there is a left atrial enlargement, what it will, left atrium will do, left atrium will straighten left heart border first, then it will protrude through this border as a left atrial appendage, then it will cause cranial widening, and later on it will cause a double atrial shadow. But left atrial enlargement in a child, we had discussed it and somebody had correctly labeled it last time. Actually, I was a little bit confused about the child with such type of presentation with MS. So someone had said these golden words, that this patient is having Lutembecker syndrome. So someone had diagnosed from our group only. So MS plus ASD. So left atrial enlargement was pointing towards the MS. There was ASD as well. So ASD is presenting in the child as a congestive pattern here. Some people call it a mustache sign. Usually what happens, the normal blood flow, it will gravitate to the lower lobes. So there will be congestion in the lower part of the lung. And whenever such type of congestion is seen in upper part, so mustache sign, again, it is a local terminology. See here, a treated case now. What you are looking at is what exactly is this thing? Some metal is here.
Yes, that is valvular replacement.
Metal valve.
And you can also see these sternal sutures. So metallic sternal sutures are here on this side, and this one is a case of mitral valve replacement. This case also we had discussed. Again, difficult case. Just comment about a cardiomegaly.
Boot-shaped heart.
Boot shape it.
Yeah, it has the shape of the boot, but boot-shaped heart infrequently you will find in adults, as this one is characteristic appearance of the Tetralogy of Fallot. We will also see, if at all we are coming across, we can also see that particular radiograph as well. What I wanted to point out is towards this pericardial calcification. Although this is not a pericardial calcification can appear like this, and this condition is known as constrictive pericarditis. In India, usually it is secondary to the tuberculosis. So pericardium is calcified. So because of that, this is a restrictive cardiomyopathy, or restricted type of the disease in which heart fails to dilate properly. So constrictive pericarditis is a pericardial calcification. In this patient had a MI. Because of that, there was a myocardial infarction of that particular wall of the left ventricle, and it had distended and formed the aneurysm, which got calcified. So this one is a calcified left ventricular aneurysm. This one is a good case. Actually, I have opened both these images. This one is a magnified image showing the same. What is this sign known as?
There is consolidation. in the right upper zone.
Yes, if this patient is a known case of tuberculosis having large cavity, then some fibrotic changes are also seen here. You just try to comment about whether it's single or whether these are double thing. Look at these particular findings carefully. So in a cavity,
There's a ball of mycosis or something.
yes. So there is fungal ball, what one can be
Fungal
seen.
ball.
Yes, fungal ball is here. There are two cavities. A small cavity is here. The larger one is seen very well. And this sign is called meniscus sign. So it is taking a shape of meniscus. So meniscus sign, this one is the air within cavity, this one is a fungal ball within cavity. If you will change the position of the patient, this fungal ball it is a freely moving, so it will also change its position. So this one is fungal ball. It is not that dangerous condition as compared to the invasive aspergillosis, in which there will be a typical sign like finger glows like sign. So finger glow sign, which is frequently seen, all these bronchi, they will get mucus-filled bronchi, and with peribronchial cuffing, they will appear like that they will give a typical appearance like that fingered glow sign. Okay, so this one is Aspergilloma or the fungal ball. Just try to diagnose it. You can give whatever diagnosis you feel like. You will be
Pericardial effusion.
okay. Some cardiomegaly part you are feeling like okay, there is some cardiomegaly part. Look at the left lung.
Left side is gone completely.
Left hemithorax is opacified, but you can see air bronchogram sign very well. Can you see this air bronchogram?
Yes.
Beautifully seen air bronchogram. And what is the age of child? You cannot see even a head of the humerus. The humeral head will appear by the age of 1 year. So this is less than 1 year. So such a neonate with such type of finding is there. So this one is just a left lung consolidation, and you can see that air bronchograph sign very well. So this one is the air bronchogram sign. Again, another wall. We had seen mitral wall. Now this one is another wall. Can you see this wall? This one is the aortic wall. Okay, so aortic wall will have such type of appearance. We'll have a ring and we'll have such type of things which are protruding within the aortic lumen. So this one is the aortic wall. Now diagnose this. Patient came to the casualty with history of breathlessness.
Left-sided pneumothorax, sir.
Very good. But
yes.
type of pneumothorax.
Tension pneumothorax.
This one is there is a shift of mediastinum and heart to the right. And what one can see is this one is a collapsed lung. So collapsed lung is there, almost gathered in the center, and such type of shift is there. Simply do a small manual. You can have that vein flow. You can just put a needle in second intercostal space anteriorly in the line that you look for the midline, mid-clavicular line, or you can just look for the nipple, and in the same line, you can just palpate the second intercostal space and put the needle directly, and you can see that hissing sound, releasing all the pressure within the that tension pneumothorax. And once that hissing will stop, you can just remove it. Or else, if at all you want to put it, you can just put it under a water seal. So water seal, it is very easy to prepare. You can just Google it and you will get it. So this one is a tension pneumothorax. Another case. How that heart is appearing. This is what exactly you were talking about, boot-shaped heart.
Boot-shaped.
So boot-shaped heart in a child, okay? In adult, infrequently will come across that shape. So
TOF.
Yes, it is TOF. So in a child, if you will come across boot-shaped heart, look for the lung parenchyma. How about vascularity? Hypovolemia. No vascularity. Pulmonary stenosis is the most important component of the top. So boot-shaped heart with pulmonary stenosis will be always there. So this is cyanotic type of heart disease. So pulmonary stenosis, because of the pulmonary stenosis, there will be a backflow of the blood and there will be right-sided heart enlargement, right atrial enlargement, right ventricular hypertrophy, or right ventricular enlargement. And in order to release this pressure, there will be a open VSD. So VSD, and just above the VSD, there will be overriding of the aorta, taking blood to the systemic circulation. Pulmonary is already blocked. So these are all four components, right from pulmonary stenosis, right ventricular or the right-sided heart enlargement, along with that VSD and overriding of aorta. These are four components of tetralogy of Fallot. Tetralogy means four findings. So whenever these babies, they are having their PDA. PDA is a patent ductus arteriosus. So ductus arteriosus is patent. This child will not have any cyanosis. But once that will be closed, then this child will start with the cyanosis. So we have to take care not to give endomethacin like drug, which will cause a closure of PDA. So oligemia or pulmonary oligemia. So pulmonary oligemia, no vessels are seen in the lung parenchyma, as pulmonary stenosis is there. So pulmonary oligemia is a hallmark of a tetralogy of Fallot, which is secondary to the top. What is this? This one is a nasogastric tube or the feeding tube, what one can see in this particular video. Yes, diagnose.
Gas under diaphragm.
Very good. So gas under diaphragm is always an emergency unless and until that patient is already operated and post-operative diaphragm free air is there in for the post laparoscopy or laparotomy. Anyway, this one is gas under diaphragm and maybe because of the perforation peritonitis. So gas under diaphragm is bang on diagnosis. Can you name any two signs related with this condition? Just Google it, you may find them. What are the Roberts sign? What is cupola sign? What are different signs? You may go ahead with. So cupola sign.
Regular sign.
Regular sign is you can visualize both walls, from internal and outer. Both part is having air. So bowel you can visualize very well. You can see the wall of the bowel. Football
Regular sign we seen in the abdominal X-rays also.
Yeah, abdominal X-ray. So cupola sign and yes, this one is very simple diagnosis if you know where to look for. This baby is unable to feed. So why it is so?
Nasogastric tube is gone in wrong direction.
Actually, they tried to
Twisted. It got twisted.
put the feeding tube, and what one can see here, there is a complete closure of the esophagus in this particular region. So esophageal atresia. Esophageal atresia, what one can see here is the air-filled abdomen. So air-filled abdomen with such type of, so esophageal atresia and associated this rest of the esophagus is communicating with the bronchus, and that's why there is such a aerophagy. This is type 2 top, but it is not tetralogy of Fallot. It is a tracheo-esophageal fistula. It's a TEF. This one is tracheo-esophageal fistula. This one case, again, we had discussed it. We are having two views, lateral and PA view. This one is the azygoesophageal recess. What do you find in azygoesophageal recess is such type of fluid level. So it can be secondary to hiatus hernia, epiphanic, diverticula, or it can be secondary to the ecclesia cardia. Try to find out where is the problem. Something is wrong with bones. Can you pick up something is wrong with bones?
Right scapula.
Yes, we frequently forget to look for anything wrong with the scapula. See here, right scapula is showing such type of bony outgrowth, typical cauliflower-like or the exostosis. So this one is a case of osteochondroma. So single osteochondroma is there, which is involving right scapula. This case also we had discussed. Multiple findings are there. Try to just label it one by one. Airway is okay. Something is wrong with the bones. Cardia is okay. Diaphragms are okay. Effusion is not there. Lung field, something is wrong with lung field. So you have to concentrate on B, F. Gastric bubble is normal. G also forget about. Look for the hidden areas. Look for the extrathoracic soft tissue as well. See here, left breast shadow is absent. So left breast shadow is absent, means left-sided mastectomy is done. Left-sided mastectomy, what these things can be, such type of
Metastasis, static
lung-
lesions. Mets.
just by looking at a lung mets, you should look for something else as well. You can see some skeletal metastasis as well. So skeletal metastasis, and these are all in this mastectomy case. These are pointing towards malignancy. So breast malignancy with lung and skeletal mets. Last case we will discuss today. Almost our time is over. We are yet on the chest. We had all those almost, I have 50 or 60. So this one is a case of, where is the abnormality? Right lung, left lung? Okay, left lung is abnormal.
Left lung.
Left lung.
For the hidden areas. What are the hidden areas? Bilateral apical, bilateral hilar, retrocardiac and subdiaphragmatic. So what is wrong with retrocardiac region? This one is wrong. What you can see is this one is a left lower lobe collapse. So left lower lobe collapse will present as such a triangular shadow which will be there in retrocardiac region. So this means the hidden area. So we will stop here. We are having other things as well. So we will study it later on. So radiographs, chest, actually we will not be repeating it again. We have already repeated it twice, I think. In next lecture, we will go ahead with other radiographs other than chest radiograph. Maybe few or other.
But it's pleasing to see that after even after a long gap, they almost all of them have picked it rightly.
Yes, sir. So we are having so many things.
It's very pleasing.
Yes, sir.
We're
So
going in right direction, and our motto of this course is fulfilling mostly.
yes, sir. Yes, sir. So we will go ahead with other radiographs as well. Skeletal radiographs we have.
Shubharatri.
Shubharatri, sir. Shubharatri.
Good night,
Good
sir.
night, sir.
Night. Good night.